Hi, I'm Dr. Jeffrey Antimarino from Bellissimo Plastic Surgery and Medi Spa, and thank you for joining us for our Facebook Live. Tonight, we are going to talk to a very special friend of mine, Dr. Diana Breister Ghosh, who is a plastic surgeon, board certified in San Diego. Diana and I trained together at USC and did our 3 years of plastics fellowship training together. And so it's been a while since we really kind of hooked up and talked. And so we were just been kind of catching up, and we thought it'd be kind of fun to talk about her practice in San Diego, which is, as you know, is a beautiful place. And we want to talk tonight about everything breast. So anybody has any questions, feel free to type them in and we'll be happy to answer them for you. But we want to talk about breast surgery, how it, what's it like in her practice, what's it like in my practice here in Pittsburgh, and kind of go from there. So Diana, welcome, and so good to have you.
Hi, great to see you.
So in your practice, you're in private practice by yourself, and so just like I am, so we're not affiliated with any hospitals, but in your practice, now we've been in practice, 20 years, and how much, what's the breakdown of the surgeries that you do? What are the most common things that you're doing now that we've kind of gone through the stages of early on, middle, now we're sort of in the highlight of our career. What's the breakdown of types of procedures?
I would say that about 30% of my practice is going to be tummy tucks and body surgeries, liposuctions, things like that. Probably 40% would fall into the breast category. That would be augmentation, a lot of capsulectomy, implant exchange, a lot of mastopexy, and those sort of things. And then the rest is probably, facelifts. I do quite a few facelifts. They kind of come in spurts. Sometimes you get quite a few. And, facial work such as eyelids and face. I don't do any rhinoplasties or otoplasties. So that's probably pretty much the breakdown. It's like, 30-40% breast, another 30%, tummy, abdominal, and then the rest face. And then there's small part of, there's insurance breast reductions that I do as well as the breast reconstructions.
Good. So you're doing all of that. And mine's pretty similar too, as we've gotten, I don't want to say older, but more seasoned, we are doing a lot more facial stuff. And you're right, it comes in kind of spurts in different times of the year, but the breast surgery is still the main part of my practice, probably 40 or 50%. And then the rest, again, there's a lot of body contouring. But I'm seeing a lot more faces and eyelids, and especially in men.
Interesting.
So it's kind of interesting. If you'd asked me a few years ago, I think for me, liposuction was probably the most common male procedure I did. And now it's a distant third behind gynecomastia and facial surgery. So I just did a gentleman today with all 4 eyelids and a face. And so it's not uncommon for guys now, and I think it's becoming more mainstay. But so tell me about when ladies come to you for breast surgery, it's always interesting, you as a woman, do you think do you have women that really, do you kind of feel prefer a woman over a male plastic surgeon?
I definitely, obviously, think a lot of women that come are looking for a more of someone they can identify with their issues as a woman, because many women will say, I do feel like you get it, and can really identify with them. So I do believe that the women that gravitate towards a woman have probably had a woman OBGYN, or they just feel more comfortable, exposing their anatomy, exposing the parts of themselves that they may have been a little scared or ashamed or shy about. So I think that, definitely as a woman, I will get some of the more timid people that are a little more, just embarrassed, because it's a little easier, because even they have a hard time, exposing themselves sometimes. So I think there's a comfort level that, women sometimes gravitate my way.
Yeah, I think we still have a little bit more male predominance in the field. So So I don't see that as much here, but it's always something in the back of my mind. If, do women feel more comfortable? But it's interesting how many women prefer like a male gynecologist. And, I think, I guess it's just a female preference, but
it boils down to just comfort too.
yeah. So I think the biggest thing that I've kind of gotten away, how I do my consultations. So how do you talk to a lady that comes in? Let's just start with I guess the most common one. So a lady comes in and wants to talk to you about a breast augmentation.
Mm-hmm.
How do you talk to her or have her talk to you? How do you have her describe, where she is and how she wants to, what's her goal?
Yeah.
I mean, how do you have her attack that?
Yeah, so obviously, we as surgeons want to get into the mind of our patient because we want to know exactly what they're thinking. It's hard to know. So it takes a little time. So initially I will ask them, what are they? First of all, I do use cup sizes as a reference range. Okay. And it's not something that is exact or scientific, but we know an A is pretty small. We know a B is pretty small. C, you're getting into more of a middle range size. It's very common. Most women like that C range. And then there's the D. Okay. And we all kind of identify the D with a fuller breast. Right. And then double D is much, much fuller. So, I will always ask them, so what size are your breasts now? So this is before we've taken off any clothes or anything, because a lot of times they'll come in, they'll have either a push-up bra, who knows? Right. But you don't really know. And so I always ask them what size they are, because that gives me a baseline of how they even view themselves. Right. Oh, I'm an A, or I'm a negative A, or I can't even fill a B or whatnot. So that gives me a good starting point. And then, we'll talk a little more and I'll say, what size do you envision for yourself? And it's a very vague question, but I can immediately get a good feel from that, because a woman will say, oh, I think I want to be a D, and so right there, I know she wants a fuller breast. Okay. And sometimes they'll say, oh, I don't really want to go that big. I want to stay pretty small. I think no bigger than a B plus. I'm just looking for, so that in those, first early stages, it gives me a lot of insight into what they're thinking. And from there on, we have more conversations. Eventually I go ahead and examine them. And then we start talking what's realistic for them as far as their anatomy and profiles and how, tight things might be. I mean, if it's a woman who's an A and has no breast tissue, obviously we're not going to be able to put 500 cc's in there and still look natural.
Right. Right. So when, because I've kind of migrated away from that over the years. And so it's always nice.
Yeah. Talking about cup sizes. Yeah.
Right. And so it's always interesting, to talk to other colleagues, to talk about how you approach it. And I used to do that all the time, but I think I've gotten away from it because I feel like women have been sort of beaten into their heads that, as you said, if you're a C or a D, you're okay. If you're a double D, you're too big. If you're a B or an A, you're too small. And that may not be true, depending upon the body habitus.
Right, right.
I try to tell them, from the beginning. And so my approach is, I always say, without using letters.
Yeah.
What do you see with your breasts? And where would you like to be? And I want you to sort of just describe it to me, what you want. And so, and right now the trend is great because most women just want to look natural. Yeah. And so, and I'll ask them, so do you want to look full enough that you look augmented, or do you want to look still full, but still a natural fullness? And so, because what I found is that over the years, when we talked about cup sizes, what I think is a C or a D,
absolutely
aligned with what they are. And I think as plastic surgeons, like you said, we're trying to get into the heads of our patients and find out what their goals are. So we want to meet their expectations. And so we're constantly managing that. So if a lady says to me, I want to be a D, and I think, okay, I make her what I think is a D, she may be happy with that. So I've kind of gone away from that, because and we'll talk about sizing in a little bit, because the way I've kind of been able to get away from it is because the sizing that I do, I feel for me anyway, is pretty accurate. But I
Hmm.
tell them I don't want women to feel, I want them to go for their look. I want to define their look.
Right. Not to be married to a size or a
Right.
number.
And
Yeah.
so, and I think that's the thing, because it was years ago, I had a lady that I did a breast reduction on, and that was another one we'll talk about is how do you choose how big they're going to be? And you kind of just get a feel for it,
Hmm.
but
Hmm.
she came in and she said, I love it. I'm so happy. I feel so much better. I love it. But I'm upset because I wanted to be a C and I'm a small D.
Hmm.
And
Hmm. I see
love it.
that. I hear that too.
Right. But see, in her mind, though, a D was too big, even though she liked it, the look.
Yeah.
And so I
Hmm.
try not to marry that together at the beginning of the conversation with them. So for me, it's just, I don't want to get stuck. Remember, in the older days, we used to have them bring in photos and we'd put them up in the OR and stuff like
Yeah.
that, just to try to match that. And
Yeah.
to me, it's a little bit harder, but I want women I want them to feel good about the way they look, and that's what we're going to try to do. So how do you size with them? Do you do cameras and 3D imaging? How do you do that?
So I'm pretty old school, old
Mhm.
fashioned. I don't have any kind of imaging or anything like that. I basically put them in a bra
Mhm.
and I fill that bra with an implant. And we'll start with, I just choose one that I think, may,
Mhm. Turn them off down.
may work for them.
Mhm.
Okay. Now, this can be harder when women already have a lot of breast tissue already. That's a harder technique,
Mhm.
but for the most part, it works quite well. And so we have a starting point of, okay, put this on. I really don't tell them what size it is or
Right.
number. We put it on, she puts on a tank top, and I just have her look at her body and look at the
Mhm.
proportions and look around and just kind of get a feel like, is this kind of what you're going for? Because automatically they'll have a gut feeling of like, well, definitely no, this is too big, or oh yeah, I think I could go a little bigger than this, or something. They
Right.
have a gut reaction to that.
Right.
And so from there, I start kind of tailoring it. I personally never promise anyone I'm going to put a certain size in.
Mhm.
I always say, listen, this is kind of the range I see you in.
Right.
And we are going to, when I get in there and see how your pocket, opens and how that looks, I may be able to get a little more or a little less. You may wind up with something in that range.
Right. And I do exactly the same thing. And it's kind of funny, again, trained together, but two different coasts,
Mhm.
20 years later, we sort of migrated down the same way.
Uh-huh.
And that's what I'm saying. You can sort of pick the style of implant after examining them, which style of implant might work best for them. And then you kind of get a feel for them anyway, and you just sort of start them off. And I just do the same thing. I have them in a sports bra and a shirt, and
Hmm.
have them, do you like this look? And I usually tell them, you'll know the tipping point when it's too big. And
Hmm.
I just keep kind of moving up and down until they
Hmm.
feel comfortable. And
Yeah.
I just tell them, see, for me, that's better because now I have an objective number.
Yeah.
And I usually
Me
tell them
too.
the same thing. There's going to be a little wiggle room because in surgery, the ribs might be a little different, the pockets may be a little, so you might, even though one side might be a little bigger than the other, you might still need the same size implant, and we kind of balance it out. So I sort of get the last, final say of what it's going to be, but
Yeah.
it's not like she's going to pick a 350 and I put in a 600. It's,
Yeah.
they're like, 325, 350, 375. They're
Yeah.
sort of in the same range. And then I tell them that's the only time I'll talk cup size. I say, so if you understand that, even though I might tweak it a little, it's not going to change your overall cup size from what you would normally look. So that way, and since I've done that, I've been doing that for, I don't know, at least 10 years that way. And I tell
Hmm.
you, it's very rare that,
Works really well. Yeah.
but because at the end, I want them to come back in and say, this is perfect, and I was telling them, yeah, because you picked it. But I
Right.
always tell them I have 3 non-negotiables, so I don't let them get anything wider than the width of their breast, and
Yeah.
I talk to them about that. And I always put the implants under the muscle, and I'm sure, especially if you're doing breast reconstruction, you're going to feel the same way. And we go through that, and just sort of how you do it. And it's kind of funny as you kind of migrate through, your experience levels. it's
Hmm.
a lot easier to kind of go through that with ladies and tell them this is
Yeah.
the way I do it. And I've never had anybody walk out the door disagreeing with me, but
Right.
explaining to them. So it's interesting. We kind of get to that same point.
Hmm.
And,
Yeah.
so how do you talk to a woman who wants a breast reduction about size?
Well, I do it in a very similar fashion. And I know you don't like the letters. I'm a letter person. So I let them, I say, hey, what size are you now? And if they're saying like a double H or something, I know, okay, we are talking,
Right.
very large breasts. And then I do always ask them, what is the vision you have? Like, and I do say cup, even though we know that a larger woman can't have a C.
Right.
But I like to hear what she says. I like to know,
Mhm.
oh, and there's many, many women who are adamant about wanting to be a B cup.
Right.
And what that just tells me is that they want to be as small as possible,
Right.
as small as I can make them. I tell them, listen, there's no way you're going to wind up a B cup. But I'm asking you that because I will more liberally take out the tissue,
Right.
and be a little more aggressive, as long as you know that, this, it may not match your body as much. But so, and if they do say like full C, small D, which we all know that's impossible to achieve,
Right.
there's a million bra sizes, but I do know that she would like to maintain a little volume.
Right.
So then I talk to them about their body habitus and what's reasonable, and many women who are just adamant about wanting to be that B, but they're heavier women. I say that's not going to work in you.
Right.
I can make you dramatically smaller, but a B cup is just not feasible. Your breast is too wide.
Yeah. And so, and again, so that's about the time when I do the same thing. That's when I'll kind of venture down the cup size with them, just so
Yeah.
they get an idea. But, and I have to, I try to tell them, especially for a wider breast, is that, if you do that, you're going to change the shape that it may not be that aesthetic, even though we're doing it for functional reasons, for to alleviate
Yeah.
pain and discomfort. It still has to look good. I mean, it's a woman's breast. So I tell them, and then the other thing is it flattens out the breast a little bit too. And I
Yes, it
think the
does.
problem is that, you spend your whole time pulling your bra up now to sort of hoist them. But if you make them too small, and that can be a possibility, is that now you're going to spend the rest of your time pulling your bra down because it's going to keep slipping up. And so you
Yeah.
don't have enough tissue to hold the bra in place. And so, and I think, because women don't really have a reference point, I say, if you're really in that EF category, taking you down to a double D is
Significant.
worlds of difference. And so
Yeah.
it really is, that lifting part. And
Yeah.
so, and then the other thing is, it's kind of come up recently in the last couple of years, which I never really thought about, is I had a few women that came in and said, they wanted to talk about a breast reduction. And then I said, okay, well, this is, how we do it. This is where the incisions are. And then they said, well, what about the lift? And I said, well, it's part of the operation. I mean, it's a lift and reducing. That's the difference between a straight lift and a reduction. And the reduction is both. And I had several women say, well, they went to somebody and they were given the price for the lift, and then they were going to charge the insurance company for the reduction. Oh, wait a minute. So that kind of opened my eyes that there's some stuff that's going on out there. So I always tell them now, listen, this procedure is great because it's 2 operations in one, and you will get the lift, because for some women, that's 60% of their issue is the sagging of the breast, more than anything. So it's interesting, but I still do a fair amount of breast reductions, and they're just really happy ladies.
Do you, what is your favorite pedicle?
I still do inferior pedicle.
You
I
do?
still do it the old fashioned way. I get great results with it. And for me, it's very predictable. And at this stage of my career, I want to be predictable. I want to know, especially if I'm managing that woman's expectations, I know with that kind of procedure the way I was trained to do it, I've modified it. I do it a little differently, or a lot differently than we were trained, but so it's not really, it's almost a central pedicle for me.
Is it?
Yeah, I mean, I leave a lot of tissue behind and in the center, and I sculpt it out. So, because I want that nice full round breast.
Right.
My goal is to make the reduction patient look like an augmentation with their own. So, and I got that actually from Jim Anderson, who we trained under, is that that's sort of the way he did it. And I really thought it gave the best results. So I do some different things to sculpt out the breast so that I get that nice full breast rather than the way you're, taught, cut, ABC, and then pull it together. And it just, anybody can do it that way. But so I've just sort of modified it over the years. And so I really do like those results a lot better.
Yeah. Excellent.
What about you?
I have switched a little to more of a superior medial pedicle, and I don't know. It seems to just work a little bit better to me. It makes a lot of sense because I take out a lot of weight on the bottom of the breast. So there's a lot of weight, but I'll do different techniques for different women.
Right, and that's kind of the fun part too. Being in practice this long, you kind of vary it to where you want. Yeah. I guess the biggest combination that I'm seeing now for the last probably 6 or 7 years is the augmentation mastopexy, like the full mastopexy.
Yes.
And that's something, we could sort of, when we were younger, shied away from, but now it's almost, it probably, of all the augmentations I do, I got to tell you, the large percentage of them are with a lift of some type, but the full lift and then just sort of walking through those waters. But it's nice because now we're old enough to, to do that on the fly almost, to say. It's really a fun operation because you can really, again, build a woman's breast where there really isn't a lot of volume and a lot of sagging. And then you can really reshape that whole breast in a couple of hours and it's completely different. So I really enjoy those a lot. And are you seeing that same?
Yes. Yeah. We will have to do another conversation about some of your techniques on that too, because it's always a little challenging and a little dicey. Always a little nervous about devascularizing the nipple, but they're hardy usually, I think.
Yeah, what's funny is that's another one that I do completely differently than I was trained. I mean, I think the way we were trained, or everybody's trained, is backwards, and so changing that around is. I don't worry. I mean, the vascularity of the nipple is great, but, instead of trying to do the way we were manipulated, but we'll definitely talk about that. So I might have to get you out here and do something better. But the other thing that we're seeing a lot of, or at least a lot of ladies inquiring about it, we talked a little bit about it before, and is fat transfers for the breast. And personally, I use fat transfers as part of my breast reconstruction as a revision if I need it, to kind of fill in some areas, especially for lumpectomy, patients with lumpectomy and radiation. So they have that concavity. I think it works great, but I'm not wild about the idea of trying to build a breast with just fat. Most of my patients that want it are the really young ladies that really have no extra fat anyway. So
I know. That's the other part. Yeah, they usually don't have nearly enough.
By the way they look, it's like you're not even a candidate. I don't even have to examine you. But are you seeing that? I mean, in Southern California, is that more popular there?
We do get quite a few inquiries for the fat transfer of the breast, and I find that most people are not going to be good candidates for it. Number one, I don't think it can do as much as they think it can. We all know that there's a large percentage of the fat that gets resorbed and doesn't stick around, and that the unpredictable nature of that can be hard to tell a patient. I mean, I think you and I, we want to have expectations, and just saying, listen, we don't really know exactly how much fat is going to stick around, and if it's going to make a considerable difference in their volume. So I have done several of them, but it was in women that were very adamant about just they knew the limitations of it. So I think you have to pick the right candidate for that. But I find that I don't find it to be, moving up my list of procedures anytime soon.
Right. And I feel the same way. So I've done several on my own, but those women are usually fuller breasted women anyway, and just have,
Right.
that concavity on top. And that's all they want filled in. They don't really want to be anything different. I think it works okay there.
Hmm.
But I think if you have somebody who's an AB cup, and when I really tell them, we talk about fat grafting to any place, I tell them sometimes it takes 2 or maybe a third surgery. And so when you start looking at, I tell them when you start adding up the costs of that, it
Hmm.
can be very feasible. And I half jokingly say, when women come for a breast augmentation, I've never had a woman come to me in 20 years saying, I don't want an implant, but I'll take 3 surgeries over a year span and I'll spend 3 times the money to do it. I mean, nobody wants to wait that long. So when I kind of go through what, the limitations of fat transfers, I have very few, even the ones that are candidates, the ones that aren't candidates, we don't even have the conversation. But the
Yeah.
other ones are like, oh, I didn't know that, because there's not a lot of information about that out in social media and on the internet.
No.
It's not talking about that. So, the educational part of that, I think, is once women really hear the reality of it, they're not
Yeah.
going to want to do that.
Yeah. There's not a lot that want to go for that, really.
Well, the scary thing for me is I still do a fair amount of breast reconstruction. And so talking to some of the radiologists, my worry is that, sometimes when the fat doesn't survive, it
Yeah. It
calcifies.
calcifies.
Yeah, so now you're going to see that on a mammogram. And the radiologists have said in the past, well, we can tell the difference between microcalcification of a cancer versus fat necrosis or calcium deposits from fat necrosis and scarring. And I said, okay, well, I still felt funny about that, but I just had a recent case where I had a lady, I did a mastopexy, a lift, and an augmentation. And she had a small area around the nipple where we see a little bit of fat necrosis from the cautery. And we talked about it, and I said, most likely it's fat necrosis, and she was a little worried about it. So I sent her for ultrasound and a mammogram. And they were concerned. They said it was suspicious. They were worried about it, So then they couldn't set her up for a biopsy for a couple of weeks. So she was worried about it. Then they did the biopsy, took a few days for that to come back, and it turned out to be fat necrosis. But that poor woman went for
A
about
whole lot of worry.
well, she didn't need to. And so my feeling now is, okay, that solidified me, because these were the person that read it out was a very good radiologist.
Yeah.
And I thought, well, if that just a normal surgery could cause some confusion, what if you're putting fat everywhere now? And I said, I don't want to have any of my patients have to get unnecessary biopsies, probably, for the rest of their life, worrying that we have breast cancer with 1 in 8 women. So breast cancer is going up and up and up. So the suspicion goes up. That's a hard way to live when you're worried about, especially for us that are doing the breast cancer reconstruction. So we know what those ladies are already going through that truly have it. So I just don't want to put that fear into women or that anxiety. And
Yeah, there's no need for extra anxiety in this world already. And like you said, 1 in 8, we already have a pretty high risk. We don't need to add any complications to that.
Exactly. The last thing I want to talk to you about is the thing that is cleavage. And sometimes, women will come in and, like you said, their anatomy doesn't support it, but they really want those high breasts. And sometimes they just have a long torso. And I try to explain to them, look, and they'll say, but I want them way up here. And I'm like, yeah, but you can't do that. But
not where your breast is. Right.
And so you can only lift them so far. But what do you think about, ladies that, that want an augmentation and have, naturally have a little bit wider cleavage? Fat grafting can be some help in that. Do you ever do that?
I have actually never, ever done that. I feel like, I certainly would be open to it, but the reality is that there's a distance, and there's that fixed distance between, some women have really wider space between the 2 breasts, and a lot of women don't. So there's always going to be the women that their breasts might be far apart, or they say, I don't want to look like that, or I'm nervous, it's too far. And I have to say, listen, I have to be really honest. Your breasts are far apart. Right. And I can't move them on your chest. I can only make the breasts you have larger. But by nature of making them larger, obviously that's going to give you more semblance of fullness in the cleavage area, or you can try to push them a little bit, but I can't change where your breast is. So I'm pretty honest about that. And they understand it when you show them a picture and you show, if I put the implants here, your nipples are going to look over there, which it just can't happen. But the fat seems like an interesting take on that. And I'd be interested to hear if you've had some success with that.
Yeah, I haven't really done it because I feel the same way you do. I mean, I think that there's a limits to what you can do. And I think you just have to be outright honest with them at the beginning and make sure they understand that. But it is something that I might go down that line where you can help it a little bit, because I show them, if you put in implants, even though you're not really changing that distance between the breast, you're camouflaging it, because now you have more fullness there.
Yeah.
And I usually tell them the same thing. If you want more than what I'm showing you, then you just need to get a bra and push them together more.
That's right.
And that's the best way to do it. But there are some guys that are doing that and exploring that, and they show some great results. But I think, again, and I guess it depends on your market as well, because I think when you start talking to women about, yes, we can do that, take a little bit of fat, do this, but you may develop some asymmetry that you may not have with just implants, and you may have to come back for touch-ups, and you may have, some of that you can do in the office if it's small amounts. But, I don't think a lot of women really want to go down that line unless they're really adamant about having cleavage. But I just haven't seen it in my practice very much. And so I'm actually rather grateful for it. But I think you're kind of getting into some muddy waters. But I just, wanted to see your take on it as well. And it seems like we're kind of on the same boat there too.
Eye to eye.
Well, listen, we have got some other stuff we got to get to, and I know you do as well. But we will get together again, because let's talk about some other stuff that you're doing.
Absolutely, sounds great.
Actually, when Ella and I are back home, we got to come and meet up with you. So,
absolutely.
But anyway, Diana, it's so great to see you, and thank you for doing that. So,
my pleasure.
Everybody, thank you so much for joining in, and please send in your questions. We'll be happy to answer them for you, and join us next month for another episode of our Facebook Live, and we'll see you then.
Bye.
See you later.